Hi all, today I'll be presenting my Pecha Kucha presentation on subacute care, an overview and a short case study highlighting the learning points that I have gathered over the semester. Throughout the completion of the curriculum, I had never truly understood where acute care fell in the spectrum of the hospital system, but I learned that it plays a very important role in the continuum of care. Instead of 3 hours of therapy services a day, a client can get 2 hours of skilled services a day to better align with their activity tolerance. I had understood that there are a variety of patient populations that make up the census of an acute care unit, but I found it interesting that joint replacements make up a large amount of them. As we all can see from this picture, this includes knee replacements, as well as hips, and so on. Falls also play a large role in patient populations that receive treatment in subacute. Falls can result in bone breaks, traumatic brain injuries, or even vision changes. This population requires knowledge of all the many different ways in which complications could arise throughout treatment. Cognition changes as a result of dementia, stroke, Parkinson's, or delirium, to name a few, could also arise frequently in subacute. Taking into consideration the cognitive status of the patient in this setting, as well as their activity tolerance, are incredibly important for creating a treatment plan. The evaluation process can cover a wide range of topics. Through a webinar from occupationaltherapy.com that I utilized to gather some background information on subacute, these were a few of the common assessments: the AMPAC 6-clicks, MiniCog, MoCA, Effective Function Performance Test, the Allen Cognitive Level Screen, the Routine Task Inventory, and the Barthel or the Modifies Barthel. These assessments can be used in addition to observation of ADLs and chart review. Building the occupational profile is an essential part of creating a sense of what the client was like prior to their admission to the hospital system. Whether the patient is staying in the unit for a short time for discharge or going to be receiving treatment for a longer period of time, it is important to gather what is important to the client and what supports they have for future discharge. This also helps in creating meaningful therapy experiences throughout their stay. ADLs can also be a large part of treatment in this setting, as they also tend to be in acute care as well. This can include working on feeding, bathing, dressing, completing transfers from bed to wheelchair and wheelchair to commode, engaging in a voiding schedule, and increasing tolerance in safe and effective ambulation. These skills focus on what's most important to the client for wherever they might end up next, from independent living to long-term care. Teaching the use of and implementing durable medical equipment also falls within the scope of subacute occupational therapy, whether it's a wheelchair, a rollator, a walker, or other assistive devices to help the client become more independent. Again, this links back to providing the client with the opportunities to be independent and reaching their prior level of functioning. Discharge options vary greatly in this setting. I learned that from subacute, you can go almost anywhere. Patients could go to long-term care hospitals if they need continued services. They could also go to acute if they need some more intensive services. Outpatient could be an option if they're able to be sent home, or even home health services. However, COVID-19 has changed things a bit, and one local therapist has seen some readmits due to continuing complications from patients. It's no surprise that COVID-19 has a unique impact on healthcare as a whole, but has specifically made large impacts within the subacute setting. Since the start of COVID-19, the patient census has changed drastically from the quote-unquote typical cases, such as joint replacements and stroke. I was able to speak with Patricia, a subacute occupational therapist, to gain a greater perspective of how these things have changed and how the impacts of COVID have affected their patients. She was able to share her experience of her time working with a COVID long hauler and how OT was able to be a part of his treatment. It all started in December of 2021 when a gentleman in his mid-60s was put on Patricia's caseload. His condition was unstable and he was having a difficult time grappling with the symptoms that he was experiencing. The gentleman had a history of diabetes and a previous stroke. According to his medical history, he had been living a more sedentary lifestyle as well. Throughout his time in the hospital and in subacute, he had been readmitted about 5 times. The first few times he was readmitted to the hospital were related to the need of a trach. The most recent hospital readmits were due to changes in cognitive status. By the time Patricia and the therapy team met this gentleman, he already had a stage 4 pressure ulcer on his sacrum from prolonged periods of time in bed. It was unclear when the pressure ulcer started, but it automatically became a great area of concern. It was assumed between his time at home and the fatigue he was experiencing as a result of COVID-19, the ulcer had progressed exponentially. The information that I learned from Patricia aligns with the information we had learned in class about pressure ulcers. His category 4 meant that he had gotten his ulcer from prolonged pressure and sitting and laying on his sacrum. Due to this, a full thickness wound arose. This wound was deep enough to go past the skin, muscle, tendons, and left the bone exposed. The wound was so severe that all 5 segments of this gentleman's sacrum were visible with the naked eye. This was reiterated not only to me, but to the therapy team as well, the importance of adequate positioning and movement to prevent such intense and painful wounds. Unfortunately, throughout the various trips and readmissions to acute care and back to subacute, and due to the fragile nature of his skin already, this gentleman developed 2 additional sores on his hips. According to Patricia, these wounds were not as severe, but greatly impacted his quality of life and introduced additional concern for infection. The patient was not permitted to sit in his wheelchair for more than 1 hour a day due to the nature of his wounds and efforts to minimize the potential for them to worsen. This precaution was implemented in addition to a strict positioning schedule to help promote adequate pressure relief and the addition of an air mattress. Due to the nature of the complications that this client was facing, he had a very low activity tolerance, and there was not much that could be done from an ADL or IADL standpoint. So what was done in OT? Mostly trying to improve his trunk stability and try to increase his ability to handle increased time engaging in balance activities. There were also a multitude of co-treats with PT to try and get his gross motor improved. As occupational therapists, it's important to continue to provide client-centered care throughout the entire life cycle. This patient was rapidly declining, and it became time for conversations about palliative care. This is where Patricia emphasized the role of OT in advocating for a patient's wishes in the end of life and engaging with the family to help them know their options. Though this client's story was not one that comes across as a very happy one, I feel as though it demonstrates the unique role of OT and how it can be beneficial in any setting, including subacute. This story serves as an example of just how interconnected a client's history and their current status can be. Every development influences the rest of the system and results in the need for OT to stay on their toes to provide the best care possible.